welcome. We have a wonderful session today with two outstanding speakers, Dr. Yamani, who is subspecialist in emergency medicine from Mass General and also a specialist in critical care currently in George Washington University, along with Dr. Maripatu, who is is associate professor in Stony Brook University School of Medicine, with a lot of interest in medical mechanisms in kidney disease progression, focusing on development on endotoxin activity assay and use of spectral dialyzers in order to remove endotoxin and impact on patients, particularly in COVID-19 setting. I would invite our speakers to enlighten us.
Everyone can see my screen okay?
Yes.
Awesome. Good morning. I'm David Yamani. I'm from the George Washington University Hospital, and we're going to be talking about endotoxemia in COVID-19, its prevalence and relevance. So just a quick financial disclosure, Spectral Diagnostic did provide our EAA testing kits to us, and I am a co-investigator in our Tigris trial, where we're looking at PMX in bacterial sepsis and its effect on endotoxin activity. So as we know, COVID-19 is a massive global pandemic that is affecting people worldwide as well as throughout the US, and our numbers just continue to grow. It's hard to get an accurate number for this because every day the numbers change and are going up at such an astronomical rate, as we can all feel. But something that we're pretty aware of is this phenomenon, kind of cytokine storm, where we have a hyperactivation of the immune system with off-the-chart inflammatory markers, which is associated with a high mortality in COVID-19. What we also know is that there are low rates of bacterial infections in patients with COVID-19. However, what we don't know is whether or not these patients with low bacterial infections have elevations in their endotoxin, which is typically found in gram-negative sepsis in these COVID-19 patients. And what we also don't know is whether the presence of this endotoxemia has any clinical significance, namely on mortality and specifically acute renal failure. So what we sought to do was to describe simply what is the prevalence of endotoxemia in a group of patients admitted to our ICU with COVID-19. And then we sought to determine if these high levels are associated with other cytokine inflammatory markers that we know about, and to see if this has a relevance on mortality, respiratory failure, and acute renal failure, specifically the need for renal replacement therapy. So just a step back to look at our setting. George Washington Hospital is a small hospital actually, but it's in the dead center of Washington, DC. We have quite a big critical care unit there, 56 beds, and it's mixed staffed by multiple different intensivists from different specialties: internal medicine, anesthesia, pulmonary surgery, and then I'm from emergency medicine. What our COVID response looked like in our study period, Washington, DC had about 10,000 cases. Washington, DC is only sort of a medium size in terms of the pandemic. We didn't get hit like other cities such as New York, despite our president having super spreader events down the street from us. Within our university hospital, we had 2 dedicated ICUs that were 16 beds, and only patients who were requiring escalating respiratory therapies, such as escalating high flow or escalating BiPAP, invasive mechanical ventilation or vasopressors, were admitted to the ICU. Anybody who was on stable high flow nasal cannula was managed on our regular medical floors in the COVID units there. And then during our study period, 162 patients received care in our ICU. And about a quarter of these were transfers from outside facilities for therapies such as ECMO, which they're actually cannulating somebody for ECMO in this picture here. So during this pandemic, as many people were probably locked up, the same thing happened to our medical students, and they were locked up and they were suspended from classes. So I ended up with a cadre of medical students at my disposal that were quite bored and wanted to help out in terms of research and just the COVID efforts in general. And SPECTRAL had given us these endotoxin activity assays because we were running our Tigris trial. We had these lying around and they offered us sort of extra ones. And so I employed a cadre of medical students to start running endotoxin assays on our COVID-19 patients. So that we got some space in our lab downstairs in the hospital lab, and we started running endotoxin activity assays on our patients. So from March 30th to June 5th, we ran endotoxin assays for patients on initial presentation to the ICU. We divided these assays into a low level, which is sort of the normal level, anything below 0.4, an intermediate level, which is 0.4 to 0.6, and then a high level, which is anything greater than 0.6. And then once these patients were divided, we sought to see if these correlated with any of the other inflammatory markers or organ function markers. And then we sought to see if these levels had any correlation with outcome markers, mortality, respiratory failure, and renal replacement therapy. So what we found for this analysis, we had 63 patients. The average age was 56, which is actually quite young when you're looking at the patient populations. 62% were male, and for our patient population in DC, 59% were Black, which is something very consistent with, is higher than our general patient population, but is consistent with what we've seen. And then the average BMI was 31. So we did have a significant amount of obesity. Quite a sick population, 78% were intubated, and the overall hospital mortality for our patient population was 65%. So going into the baseline demographics, as you can see that the most interesting part about this slide is that if you look at the number of people within each of the groups, majority of our patient population was in the high level endotoxin activity level, which is greater than 0.6. Otherwise, the groups were the same with regards to age, gender, race, and many of our illness severity scores, as well as BMI. In terms of inflammatory markers, this actually is not that interesting. There was no sort of significant difference between the inflammatory markers. So it was just sort of high across the board, despite what your endotoxin activity level. But the interesting thing I think about these numbers are just as we've all seen, is they're all through the roof, which you've probably seen taking care of your patients. But a lot of these values were like, that can't be right. And they are, in fact, just numbers we've never seen before. In terms of the general laboratory values, the interesting thing I thought about this was that the creatinine actually is same across all groups. And in terms of positive blood cultures, there's actually a really low rate of blood cultures in specific gram-negative bacteremia, which is typically what you see in endotoxin activity. And so very low levels of gram-negative bacteremia. And so I think the most interesting thing that we found was that the mortality intubated also we didn't find a signal, but the renal replacement therapy, even though our N is quite small with pilot data, is astronomically through the roof, that it is much higher in the higher level endotoxin levels. Despite their creatinines being the same, the endotoxin activity sort of predicted better who was going to need renal replacement therapy. So obviously this is very pilot data, and we did find high levels of endotoxemia in our ICU patients, despite low levels of gram-negative bacteremia. And when present, these high levels were associated with the need for renal replacement therapy. Obviously, we need further studies to explore this association between endotoxemia and in COVID-19 patients and the need for renal replacement therapy. We currently have a data set of 94 patients, which we're finalizing our data on. And then obviously, if hopefully our numbers don't get too crazy, but expanding our data collection on new patients. Thank you.
Thank you very much. Dr. Maripatu?
Yeah, I don't know if they can enable sharing. That was an excellent presentation. I think it really helps me out because it laid the perfect background to some of the experiences that we have observed, and it's certainly it was a privilege to present some of our experiences here at Stony Brook in New York. This is actually a picture of our hospital, our medical center, if you haven't been out to Long Island, but it's a moderate-sized hospital, a little under 700-bed hospital, which during the March and April, during the thick of COVID pandemic, actually ballooned, where you can see on site, it's affiliated with our State University So these are field sites that were created to expand the hospital to close to 1,000-bed hospital in preparation for the surge in pandemic. And I have no disclosures as it relates to this. And briefly, I wanted to go over our experience here at Stony Brook, similar to what Dr. Yamani did and George Washington. And also, as he had elegantly presented on his data on endotoxemia, we actually used some of the criteria that was demonstrated in previous studies to see the prevalence of endotoxemia in critically ill patients. And also, we started using polymyxin B hemoperfusion along with Spectral Medical in terms of trying to see if this would have a beneficial effect in patients that were critically ill with COVID-19. And so this is just briefly data that's been published and is available. This is from our Stony Brook experience cohort, where during the pandemic, and especially during March, where we were seeing tremendous number of cases, we actually looked at the patients that were hospitalized specifically. We looked at patients, about 3,000 patients that came through in these couple of months. And of those over 1,300 patients that were hospitalized, you can see a significant proportion of patients where are adult patients, but also require mechanical ventilation. And we had observed a mortality rate during these early phases, a little under 50%. And one thing that's interesting, which many of you can really appreciate, is that these patients had such a long, prolonged hospital course, and as such developed several complications. And so here's Long Island, and we're situated east of Manhattan. And we were in the later stages as Manhattan initially got the pandemic. We were starting to see a large number of cases. We're in Suffolk County, and for a long time, we were in the top 6-7 counties in the world in terms of the number of cases of COVID-19 during the pandemic. And this is data that we demonstrated that a number of patient cases was highly associated with population density in the region as well that we observed, in this being Stony Brook Hospital in the region. Here are some just baseline data that we observed that a large proportion of patients were diabetic and hypertensive, which is very similar, but we also saw a significant proportion of patients that were Hispanic and young that we observed, as well as the elevated BMI in this population. Furthermore, we observed that not just many of these patients were male, majority, but also diastolic hypertension seemed to be a prevalent factor in these patients. Furthermore, here, as many of you have observed, similarly, we saw trends in leukopenia, but what was interesting is that hyponatremia was fairly prevalent in hospitalized COVID-19 patients, and we're currently conducting studies to determine the prognostic implications of that, as well as a large proportion of these patients, almost 30%, actually had some degree of kidney dysfunction at baseline. And other laboratory values here, which Dr. Yamani had elegantly demonstrated, also associated with elevated inflammatory markers. But we also saw a subset of patients in terms of, if you're evaluating kidney dysfunction, had this baseline proteinuria and hematuria on presentation, which also we've recently studied and published on, demonstrating its impact in overall outcomes in developing AKI in this population. We observed an overall mortality rate of 15%, which is higher in males versus females. About less than 10% patients did not require any mechanical ventilation. But if you did, in the patients that did not require mechanical ventilation, the mortality rate was significantly lower. But in patients that did require mechanical ventilation, you could see we had a mortality rate of approximately 48% in these early phases of the pandemic. And similar to this, we observed overall a 21% acute kidney injury in hospitalized patients with COVID-19, and 26% of these required some degree of renal replacement therapy, such as CRRT or hemodialysis. We observed a readmission rate of about 7.5%, and the disposition was mostly home versus facility, and it was dependent really on the age of the patient. What was interesting here, and this actually alludes to where we observed endotoxemia and so forth, but overall length of stay, obviously in the deceased, was much longer than if you were discharged alive. But what was really interesting here, and the data demonstrated, is that the longer the hospital length of stay in patients discharged alive after being on mechanical ventilation seemed to be attributable to a greater number of non-ventilator hospital days. Also, we saw a large number of patients, active patients in the hospital, that had a really prolonged course in the hospital compared to those patients that either died early or just were recovered early. And so these patients are actually, we've actually been studying in terms of why is their disease course so different than the patients that died early on. Furthermore here, we looked at risk predictors, and what was really interesting here, if you looked at mechanically ventilated patients using logistic regression analyses and modeling to demonstrate what's the likely impact, the highest risk factor for mortality in mechanically ventilated patients was acute kidney injury. So based on this, we did a small study really trying to understand in our laboratory, and here at Chief of Nephrology, we were actually really highly impacted in terms of getting our renal replacement therapy and all our modalities in place. So we were really needed to really prepare potentially for a second wave to occur. And so what we wanted to understand is, can we get at some of the mechanisms that might be mediating acute kidney injury in this population? So one that we really wanted to look at, and in literature review, is potential role of understanding endotoxemia, especially since that we have a potential mode of removal of endotoxins. And so we actually use the criteria of critically ill patients. And so we looked at multi-organ dysfunction score of greater than 9, and patients that did not have underlying end-stage kidney disease or severe heart failure. And we identified about 32 patients. And from those patients, we actually observed that only 2 patients had a low endotoxin level. So nearly 75% of patients have some degree of intermediate endotoxin activity, as Dr. Yamani had mentioned, using the similar criteria. And a proportion of patients also had high endotoxin levels. And what's interesting, and I think we can probably also discuss this, we actually saw a proportion of patients that were non-responders to endotoxin activity, suggesting that they had a burnt out neutrophil response and they were critically ill. And what we did observe is that if you were to just observe these patients that were really high endotoxin levels or that were non-responders, they actually had a significant higher rates of acute kidney injury requiring renal replacement therapy. And their mortality rate also seemed to have been higher than patients that were intermediate. I mean, it's a small study, similar to what Dr. Yamani had presented, but it really alludes to the fact that there may be something going on. And what's also interesting here is almost majority of the patients did not have really any, have a degree of bacteremia, and specifically gram-negative bacteremia was only present in 2 patients out of 32 patients, suggesting that maybe due to the ACE2 receptor along the intestinal barrier may have caused some dysfunction, resulting in a leaky or dysfunctional intestinal barrier, resulting in endotoxin translocation. And so we actually had conducted a couple of patients that were really emergency use for polymyx and bead hemoperfusion, and we had initially shown some intermediate benefits in terms of their oxygenation as well as their hemodynamics in the critically ill. And so in partnership with SPECTRAL, we actually enrolled in the clinical trial in use of polymyx and bead hemoperfusion in COVID-19 patients. And we conducted studies in 2 patients. And as you know, here in New York, the number of cases have really tremendously decreased, fortunately. And so we've only really had an opportunity to use it in a couple of patients. And these patients were, both these descriptions here are elderly patients, greater than 70 years of age, but one patient had some comorbidities in terms of heart failure, diabetes, and hypertension. But both that were critically ill, requiring mechanical ventilation on pressure requirements, and had a degree of acute kidney injury. And so what we did observe here in both these patients is that using polymyxin B, the traditional use where we used it consecutive days, 2-hour treatment, we did see a degree of improvement in endotoxin activity, as you can see in the high range, which did reduce down to 0.45. And we saw what was immediate that we observed was an improvement in hemodynamics in terms of the mean arterial pressure improving and patients getting off of pressors such as levothyroxine, vasopressin that they were on. We didn't really observe too much, and our initial use, we actually observed some improvement on the PF ratios here. It was pretty similar. It didn't really change too much. But what was clear is that in terms of thrombocytopenia, or we didn't observe any thrombocytopenia. The platelet counts were unchanged during this period of time. So using this initial protocol of 2 consecutive days, we saw some intermediate benefits, but subsequently the patients did succumb and they did pass away at later days in the hospital, of course, due to the acuity of the disease. And so I just wanted to briefly, our experience here at Stony Brook and the severity of illness that we observed with COVID-19, and maybe the potential role of really understanding the role of endotoxins and their impact on disease severity in COVID-19, and maybe a potential role for polymyxin B hemoperfusion. And so these are our investigators here at Stony Brook, along with support from SPECTRAL in terms of providing us the kits and also participating in the study. So thank you.
Thank you very much. This was very enlightening. Both talks were amazing in a still very uncharted territory of dealing with patients with COVID-19. Cracking this aspect open by wonderful investigators in Stony Brook and George Washington is amazing. I truly learned a lot. So what do you think the next steps are in order to delineate the impact of endotoxemia, need for potential antibiotic therapy in patients with COVID-19? Do you think that we can use that as a decision support system, EAA as a decision support system to start patients on antibiotics? As Dr. Maripatu mentioned, this could be due to translocation of bacteria in a setting of very high illness, severe illness.
So if you don't mind, I can kind of initially head at this, but I think what we really need is some prospective studies to understand the implications of endotoxemia, because we did it as a cross-sectional study, because similar to what Dr. Yamani said, we were actually dealing with these patients, and so we just measured the endotoxin levels at that time. But I think what we really need is at the time of presentation and prospectively measure the endotoxin level and the change in levels to see if we can predict whether it has an impact in terms of acute kidney injury or as well as overall outcomes. And so the intermediate benefit that we did see and the short term is very intriguing, and I think warrants further follow-up. And the protocol that we used were a 2-hour hemoperfusion, but what was remarkable and actually was in line with published studies in terms of how in terms of gram-negative bacteremia has been observed, that you do see an improvement in hemodynamics right away. In almost all the patients, the 4 patients that we presented data on 2 patients, but even the previous 2 patients, we saw a similar improvement in hemodynamics. And so I think there is something there, but I think we need further studies to really get at it.
Were your patients on antibiotics?
Yeah, so we actually had a measurement. So we did have about 50%, a little over 50% of the patients were in the study were on antibiotics at that time. So, and so one of the things that we did was look through at almost all the blood cultures, and we tried to capture if there were ever bacteremic, and we just hadn't been brought up. And so, as you know, a lot of times these patients have been put on azithromycin early on because that was part of the whole course.
And generally, culture negative septic shock patients have worse outcome in comparison with culture positives. David, did you have any? Do you have any insight on antibiotic use on patients with high EAA?
I don't have great insight into it. The majority of our patients are oftentimes started on antibiotics, but we are pretty quick to peel away our antibiotics once we've decided that they just have COVID. And the theories are that there's probably some small gut translocation And whether or not that makes a difference into their blood cultures is obviously, I guess, is not known, but it doesn't seem to be showing up in their blood cultures. And it is an interesting thought, using endotoxin activity to sort of predict the need for antibiotic use in these patients. I think we would need further studies for this, absolutely.
So what we know is that a majority of COVID-19 patients, they mostly have isolated respiratory failure, even if they go on mechanical ventilator. A large number of these patients are not in shock state. And you show that Apache and SOFA score were the same among the different EAA categories. And I assume that patients in Stony Brook were in shock state that were qualified for polymyxin cartridge, but the patients that David showed, how many of them were in shock state, and how many did you find any shock state relationship with EAA level?
So I don't have the numbers for the number of people that were in shock state for our cohort that I presented right now, but we had some cases similar to Stony Brook. We actually did use polymyxin hemoperfusion in a few patients as well who were in a shock state. And we had similar outcomes, that we had an immediate benefit. These patients were in severe shock states, on multiple vasopressors. And what we found was, unfortunately, they ultimately demised, but we did have a immediate and moderate term improvement. These patients, we were surprised that they were alive at 30 days after their hemoperfusion treatments.
So, and if you showed the EAA in day 2 after starting treatment, do you have any EAA a few days later?
No, we didn't. I think we had done it up to the 3rd day. And so that's actually a very intriguing question. So because whether there is a rebound that occurs subsequently, and I think we need to study that. And I just want to just add one thing to the whole, there's some data and literature out there, and the role of antibiotics in potentially confounding your endotoxin activity levels as well. And I think a lot of our patients that are critically ill have been in the hospital for a while when we did measure it. So I think that's why measuring the endotoxin level before initiation of antibiotics might be also important to understand their role.
Right. It is obviously kind of based on Euphrates data. Patients who had the EAA between 0.6 to 0.9, they got the best benefit. And what I'm getting into is that there may be a role into continued treatment after day 2, as it is based on the protocol of these studies, based on EAA, rather than just stopping at day 2 or only 2 hours. Patients may need higher doses and more frequent studies for more prolonged time. This is again a very nice topic. I truly appreciate your insights on this topic, on very important disease that we are all dealing with. We are in Midwest now, dealing with the surge of the disease. You just had yours earlier this year. Hopefully, never comes back to the coastal areas, and we get rid of it in Midwest. I truly appreciate your insights, and I hope that your patients do well.